Welcome to the Pharmacy Podcast. Join us as we delve into the dynamic world of pharmacy, exploring the latest trends, innovations, and insights that shape the industry. Our podcast is proudly brought to you by the Independent Pharmacies of Australia Group, IPA, dedicated to supporting independent and bannered pharmacies nationwide. We're committed to connecting all member pharmacies under the IPA national brand, recognized by Australians for elevating community healthcare to meet local needs. Our vision drives our mission to empower pharmacists and pharmacy professionals. From discussions on healthcare advancements and regulatory updates, to interviews with industry experts and success stories from pharmacy professionals, we cover it all. Our goal is to inspire and equip pharmacists to thrive in today's ever-evolving landscape while championing the values of independence, community, and excellence. Today, I have the great pleasure of introducing a guest host. Andrew leads IPA's innovations team, which spearheads partnerships, professional services, and innovations at IPA. He has a proven track record of building businesses in the healthcare industry and is a psychologist by profession with expertise in leading and developing high-performing teams. Passionate about the bright future in pharmacy, now more than ever, given the immense increase in scope of practice and the newly signed HCPA, Andrew is delighted to lead today's podcast.
All right, well, welcome everybody. Guest podcaster here today, Andrew Pattinson, and I'm delighted to have an industry luminary, my guest today, Kos Sclavos AM. I'll read a quick bio of Kos because he has. There's not much he hasn't done in the industry. He's a pharmacist, was national president of the Guild from 2005 to 2013, and in the preceding period was Queensland branch president from '96. Served on a number of boards, including Guild Insurance, Epilepsy Queensland, Assistant Commissioner Health Quality and Complaints Commission. He's currently the systems architect at Pharma Programs, the chief pharmacist at DBG Health, and remains actively involved in the Guild. He's the chair of the APP conference. I'm sure we've all seen him there. And he's awarded an honorary doctor at the Griffith University, a fellow of the PSA, honorary life member of the Pharmacy Guild. And in 2017, Queen's Birthday Honours, he was awarded a member of the Order of Australia for significant service to the pharmacy profession through retail, advisory and executive roles to education and to community health. So, and those of us that can see him on screen, on a bed here today, so because I won't even ask that one. But thank you for joining us. We've got a fair bit to cover. I mean, what a time to be in pharmacy. You know, there's so much going on in the last 18 months, culminating on some huge announcements in the last 4 to 6 weeks. So we might just run through, your sentiment on the sector. I mean, what are your thoughts as we sit here today with 8 CPAs just kicked off? Are we positive? How are you feeling about the sector?
Well, thanks, Andrew, and thanks for having me. I think it's important that pharmacists, employees, owners of pharmacies understand the environment in which the 8 CPA was negotiated. We just finished APP 2023 and the government sort of invited the Guild officials to give them the bad news that we would go to 60 days. I don't think we should underestimate what a difficult task that was. The Albanese government was riding high in the polls. You know, some of us, like myself, advocating what a bad measure this was we weren't getting a lot of reception from backbenchers. They thought they were sitting high, sitting pretty in terms of being able to whack pharmacy. We saw within months, some of the government's position deteriorating in the polls because of the voice and other issues that generally come up with any government over a period of time. And I think, to be honest, there was a view that we would be fatigued into capitulation, and the Guild stood firm. Credit to Trent, in particular Anthony Tassoni, and there's an enormous team in the background. As somebody who's negotiated agreements, I don't think we should underestimate how important that is. And at the end of the day, there's a lot of figures floating around, but I guess my simple note to pharmacists is if we compare what our dispensing fee was before this to after this announcement, I think that's important. So, we're moving now to a 30-day prescription, which is $14.24 remuneration. That's a 30-cent increase in the in the dispensing fee from the 1 July, 17-cent increase in the AHI. There's a balancing payment that, it's actually backdated into last financial year. But that balancing payment, which is a unique element due to the way the government they were taking off its net profit, and originally they were only proposing gross profit. So we're effectively saying, well, we'll take away your income, but by the way, you've got to fund a service on top of whatever we're going to pay you. So there is legitimately, over $2 billion of new money in the agreement that replaces net profit with net profit. So by the time you add that 78 cents balancing item, we get to $14.24. And even with 60-day prescriptions, which was originally going to be the same $14.24, we've added an AHI of $4.79. So for simple pharmacists who say, well, tell me per script what the impact is, our dispensing remuneration is now $14.24 for a 30-day prescription and $19.03. And I think it's important now that pharmacists reset their businesses, look at that. Obviously, the core professional service of dispensing is critical. But, without a strong dispensary foundation, we could be the best clinical pharmacists, but it might be you'll be not operating in any pharmacy because we would have shut its doors from an unviable service. So I do want to pay credit to the team as somebody who understands the difficulty of negotiating these agreements. That's a strong base. And, on top of that, there's effectively, I think our lingo, and Andrew, I know you're involved with obviously IPA and services. I think we've got to segment those now into the dispensing service. We've got the professional services that are in the 8 CPA, like for example, DAAs. There's professional services, the COML funds that are outside the 8 CPA that will come up on this, what they call rapid review, that the PSA will largely be responsible for. And then obviously we've got important state government funded programs, my own state of Queensland flu vaccine. And then we've got private programs such as programs that I'm also involved with, like pharma programs. And that's just involved in the professional service of dispensary, let alone other key advice categories like scheduled medicine. So I think it is time that pharmacists sort of segment each element of their service, and it is a time for them to be able to sit down with their teams and review that.
Let's drill into a couple of those areas. The 78 cent balancing fee. It's important for anyone listening to remember that that's only on above copay scripts, right?
So at the moment, the important thing is that the additional AHI is actually on every PBS medicine. So that's key, and the balancing fee is on over the co-payment, but importantly, it's backdated as well. So that will sort itself out. There are issues you'll need to speak to your accountant with about, depending on which accounting method your accountant uses. But I guess the bottom line is, if you look at the trajectory of pharmacy remuneration, it is we don't go backwards. Originally we were going backwards, and with every incremental increase in 60 days, the situation was getting worse. So you really have to have, for pharmacies to be falling behind on average, they would really have to have an enormous increase in 60-day prescriptions. And obviously that's why the Guild calculator is critical. The Guild's released a calculator with Nostradata that literally gives a fingerprint on how the business is going to perform out of this agreement. And that's another thing that you'll see on the roadshow with the Guild, and as well as follow-up meetings. So I know the state presidents then will do a roadshow in each state. So these are not to be missed meetings, and to really get everyone to be on top of what's going on. But I guess, Andrew, the point I was saying was owners have got an interest in some of these things, but, I think it's now the best time for pharmacy staff and owners to sit down is right now. There's agreement bedded down. You need to engage the staff so they can understand the lie of the land, allocate program champions, whether it's pharma programs or DAAs or, opioid replacement therapy. We've got to set new targets. There's some of these programs, especially the ones that are uncapped, you should be taking full advantage of, where caps have increased like DAAs at 60 days. So if there's any new training that's needed, if pharmacists have said, well, I want to get into this space, I need some training, it's now the time for you as an employee pharmacist to speak to the owner of the business. And then, without monitoring how the results are going, without that performance outcome, we're not going to improve. So I think the buzzword of 2024 will be document, report back, review, and I think on top of all the ongoing announcements out of Queensland leading the way with full scope, it's a pretty good opportunity for young pharmacists to be in a profession that's going to be very professionally satisfying. And the sky's the limit in terms of some of these services, as we've seen with announcements across Australia.
Yeah, we might drill into a couple of those points. I think certainly from our group perspective, and we've worked together on some of the data across IPA at the moment. It's about 11% of eligible 60 days. It's critical for pharmacists to remain vigilant. We're still seeing a lot of 60-day scripts that aren't really what the policy was designed for. New to therapy or dose adjustments. And so that, whilst we are getting the 2 AHIs, it's important for people to remember they are only getting the 1 dispensing fee. So do remain vigilant. It's a fantastic outcome. But we're certainly saying to members, we really, you need to be collaborating with your local healthcare providers to make sure you're getting the best patient outcomes still.
And I think that's important on pharmacy. The simple message to me is that everyone's busy. The productivity-wise, it's difficult for pharmacists. We're already burdened with a lot of administration with different sort of administration programs across all the various programs. But by setting targets, the sort of example that I would give is, we've got a scenario. For example, shingles vaccine is the one example I use. It's a 2-jab process. We're very much with the cohort of patients that visit pharmacies each and every day. And the target is that there's 16% of Australians are over 65 years of age. That's a qualifier apart from Indigenous background. But let's keep it simple in terms of the mix. If you just use this analogy on shingles and use the same principles across other programs, you will maximise the benefits of HCPA. So, that's about 4.2 million Australians, and that works at about 700 people per pharmacy that would qualify for this program. But again, sadly, we've only got 3,500 pharmacies participating in vaccination services. Yeah. So the increases the upside for the pharmacists doing this to about just over 1,026 patients per pharmacy would qualify for shingles vaccines that are visiting you potentially in your local area. So I'm aggressive. I'm bullish on these targets. I'm saying out of that, the pharmacy should be targeting 400 patients for these services. These are our frequent flyers. These are people you do the DAAs for. These are people you've probably done the flu vaccines for in states where the state governments are funding. And therefore, that's 2 times 400. That's 800 services. And, a reminder that while pharmacists would love to get paid more, that's still $18.85 per service. So that's just one subset of a sub-program and a very small program. That's something that a decade ago we would have loved to have in pharmacy when I was negotiating agreements, because that's an opportunity for the very well-known patients in our business to be approached. And you've just had to have a relative who's suffered from shingles. I've had one who sort of lost eyesight in one eye, and that's what motivates me to keep talking about shingles vaccines and the essential nature of them. But that's just one example, Andrew, where what I've replicated there, pharmacy teams should do, and each pharmacy is going to have someone who's passionate about a particular element, whether it's a professional services such as a vaccine, but we need to also get that base up. 3,500 pharmacies only that are providing these services means there's a lot of money on the table that, even the national president, Professor Krentumi, has said, you need to participate in money outside of the agreement to maximise the viability of your pharmacy.
And I think to pick up on your point there, I often wonder whether some pharmacists don't look at health services in the right context, that it's about patient lifetime value, not just about the value from that discrete event. And your point there illustrates that. It's $18.85 for a patient that needs a service. They'll get this vaccination, or that you hope they will, from somewhere. It's either, from a business owner's perspective, it's either the gross margin dollar associated with that patient rather than just the discrete event. The patient's already in the pharmacy. So, these are huge opportunities for community pharmacies just to maximise and really provide the healthcare assistance, better patient outcomes equal better business outcomes to provide those services.
Yeah, and an example, because people say, well, that's fine, Kos, give me another example where we're out in the field. Pharma Programs has just released an osteoporosis program which targets patients on Prolia. The average osteoporotic patient who's taken Prolia is the pharmacy generates around $840 of dispensing revenue a year. Now, the half glass full pharmacist says, oh, no, that's osteoporosis injection. That's only twice a year. I get $21 odd to dispense that. I'm not interested. But, the average osteoporosis patient is on 3.4 chronic therapy meds. They get 18 other PBS meds. This is data that, I live and breathe every day. So when you count just the dispensing remuneration, no trading terms or discounts from your wholesalers and so forth, that's $840. And yet this same person, the average osteoporotic patient is over 70, they're a pensioner, they're coming in for these additional services like COVID vaccinations, which we should be keeping right up to speed on with. We're about to hear I'm obviously speaking today from Queensland, and, the Chief Health Officer is warning us that there's another tsunami coming this winter with different bugs and flus and viruses. And I think that's the way we've got to look at this. We've got to look at the lifetime value of this customer, as you said, Andrew. And the osteoporotic patient is the same person, whether we're a pensioner, we were talking about taking a shingles vaccine. We've got to be a bit cleverer on how we approach these customers. And the more and they love pharmacy. Yeah. These are patients who are in our pharmacies at the very least fortnightly picking up their DAAs. And that's where I should be able to walk into your pharmacy today and say, right, give me a list of all your DAA patients and tell me what % of those have you vaccinated? And that's the sort of analytics we don't do. We don't do that well, because the first patients you should be approaching on any professional services is the people who already trust us, the account customers, the DAA customers, the flu vaccine customers, and we've probably not been as scientific about that approach as we should be. And that's where perhaps with this sort of collective sigh of relief that the agreement seems to have plugged some of the gaping holes that we were facing. And that's what I know you're also very passionate about, the systematic approach, Andrew, to how we can improve the performance of our pharmacies.
Yeah, and I know the Prolia program is one that I know we've done some work together on. I think it's a brilliant program because these are a cohort of patients, as you point out, with comorbidities that have needs. And if you go back and read the front page of HCPA, which, I'm not an interesting guy, Kos, I've done that. But the government is saying that we see pharmacy as the front line of health, and what you're talking about is pharmacies taking that coordinator of care role and actually having proactive healthcare outcomes, and HCPA really facilitates that. I think the Guild have done a brilliant job in almost decoupling the dispensary income from the program income to then really allow pharmacists to start taking that. So I guess a controversial question for, Kos, the negotiator, Kos, who was the visionary who 10 years ago dreamed of getting 1885 for a service. When we look at the 7 CPA program spend, what advice do you give? What do you say to pharmacists who still aren't, hitting relatively more caps on some of these programs? How do we fire them up?
I think, there are some older pharmacists who own pharmacies. We've got pharmacies that are subleasing off the doctor. But I think, first of all, to that cohort, we think there are about 400 pharmacies, Andrew, that, they're under pressure because they sublease off a medical centre not to have the service. These days, injection services are seen as straight line community services. And so, it is time that a pharmacy owner speaks to that medical centre in terms of some of the core services, such as flu vaccines, some of the core services, such as, COVID-19 vaccinations. There are many medical centres that have walked away, government facilities that have walked away. So it really isn't cutting across your doctor, owner, proprietor, if that's where you are. So I understand, as somebody who's helped many pharmacies negotiate with landlords where the landlord is the medical centre, that's one issue. But, even if we take that figure to be 400 pharmacies roughly I've done this analysis for one of the big pharmaceutical companies who wanted to make sure they were servicing all pharmacies. But even then, we've still got well over 2,000 pharmacies that have said, not interested, or this is too hard. In their case, now is the time to perhaps fund a pharmacy employee to do the vaccination course, and then the bridging course, which is the injectable medicines course, which is generally a prerequisite, because there's enough services now that a consult room, the physical, that used to be a temporary room, then the pharmacist said, you'd find during summer months that there was full of stock. That consult room is full now. There's no way I can build any business case to any pharmacist on this podcast that you could keep your consult room full, and that's before we enter full scope. And as we enter full scope in Queensland with other announcements, which we can talk about a bit later about how the state governments have stepped in, I'm saying to the non-clinical or the non-accredited injectable medicines pharmacists that you need to tap into that resource from whether it's a UQ, where University of Queensland in my state, or QUT, or Gold Coast, Griffith Uni, or JCU, which is leading the way in full scope. We need to tap those pharmacists because you need to have a plan. It might be a 12-month plan, but that 12-month plan needs to make sure you're embedded those services in your pharmacy. Otherwise, we're potentially talking about $20,000 to $30,000 of gross profit that you're sacrificing, that you have to make up elsewhere, and that's crazy stuff. You really should be in 2024 having a full line service, and now injectable services are seen more and more as full line, and you'll see more and more private fees on companies like pharma programs, where the drug company is happy to support the pharmacist. The Guild's principle, which is same job, same pay. So we're not going to undermine the Guild's negotiated position that that any service should be at least what we call a short consult, which is just under $19 for doctors. We're doing the same job, so we should be getting to pay the same service. So that sets the bar on where you can expect these services to be. And at $19, I can put the business case to you that that's a profitable service for you to run, no matter how many credential pharmacists you have there who are ready to do the vaccinations.
And so to build on that, to close out again, back because the visionary, there's a 30% increase in program funding with a $103 million for future programs that I don't know what will be. What do you see? What do you kind of things do you see that the expansion of government funded programs? We've touched on the private ones and the growth of biologic medicines. What else do you think we'll see?
Well, importantly, in the fine print of the agreement, we've got to understand that normally a year out from the normal timelines, Andrew, we have a review. There's a formal review of all the programs. So because of the need to negotiate this agreement early, there's what we call a rapid review. So theoretically, just to make sure that it's not all sugar and spice that we're referring to, there is potentially risk with any of the programs we've spoken about, whether it's DAA or HMRs or MedChecks or any of the services, that there'll be what we call a rapid review. And that rapid review will, at least the funding, from my understanding, is entrenched for the next 12 months. But theoretically, there could be a review and perhaps even a discontinuation, or at least a change in the program rules with regards to some of these programs. There is also a very important review of Professor Mark Cormack, unleashing, his exact words in the title is unleashing the potential for allied healthcare professionals to practice at their full scope. And so that review is expected in around October, November. How the government responds to that, we don't know. But this is not just a pharmacy focus. This is nurses, this is physios, this is other allied health professionals seeking to practice a full scope. So we could see out of that potentially new services that the Guild has obviously quarantined in the agreement, the ability to negotiate with that following the Cormack review. And I think if you read those reviews, we've got at this stage two updated reports before this final report, and it's a very strong signal that pharmacists should be embraced in the community as the most accessible health professionals to do these services. So I think the writing is on the wall that there will be more services coming, not less. Yeah. And we've had this. In fact, if you don't mind, I will touch on the state government programs now. Yeah. We've had Queensland leading the way, not because I'm just a proud Queensland, but the beauty of Queensland is that we led with full scope, but it's one thing to have. Other states have had full scope for many years, Andrew, and this is what a lot of farmers don't understand. But it was the cost of doing the course and the lack of the environment of which they could practice, where nurse practitioners have effectively non-exist in the private practice. And a lot of those nurse practitioners from, these are nurses that you well and truly respect. They've done nearly 10 years of study and done their full scope, and they're largely sucked up by the hospital scheme. So in Queensland, we had obviously the government support in terms of full scope. It started with North Queensland, and before even the North Queensland program finished, it went to the statewide scheme. But there's been a very, very important, I can't stress enough, because many of our listeners would not know that the Guild effectively funded the Tranche 1 and Tranche 2. So out of its own resources, because we knew if we were relying on pharmacies, potential students paying 10 grand, that would have been a barrier to entry. So the Guild funded the vast majority of the cost of that course, but that's unsustainable. You can't have a branch of the Guild funding, hundreds of people into it. So the state government announcement in the last couple of months were in Queensland, which is funded, the amounts are not yet official, but I can tell you out of the course of a $10,000 course, which though it may seem expensive, but I remind you, if you just have to look at MBA modules and what those units cost, 10 grand is around the mark for a course of the rigor of full scope. Yeah. So I just want to put that notion, there's been some criticism of our universities, but effectively that is the market price. And obviously, whether it's a pharmacy school, they're benchmarked against other courses of similar rigor across the university sector. And what we found is that at that mark, the vast majority, so all I can say at this stage, I can almost guarantee pharmacists that more than 50% of the costs will be funded by the state government support. And so that brings the cost way down. It'll be well under $5,000. And that, I actually think how each owner approaches this, but I do think that it'll be good for those students will benefit in terms of their ongoing negotiations to be employees of a pharmacy later on. So let's take away who needs to pay for that course, but that's now going to be, that's the bar. We've set the bar in Queensland. So if New South Wales goes to full scope, we can rightly approach the state government in New South Wales, who's also a very strong, the Premier in New South Wales, a very strong supporter of full scope. We can say, look, we need the same support here. They've proven in Queensland, they're running the full scope. We're now live in Queensland in terms of occasions of service. And I think that will allow us to roll across Australia now at an affordable level. Cost was one of the major barriers when we look at full scope overseas, when we look at full scope of other professions as well, Andrew. The cost to the student or to the pharmacist, when I say student, I'm talking about generally they're mature age pharmacists who then got backfilled. And the reason we also have to do this, Andrew, is that like the UK has just announced recently, is by 2027, you will see pharmacists graduating with this full scope qualification. Now, we expect the universities to make these announcements soon, at least over the next 12 months, where you will be able to employ a pharmacist graduating perhaps 2027 or 2028. Those pharmacists graduating will be practice ready for full scope. So you said earlier, what should the pharmacists who are not interested in this? It's all too hard for them. They're flat out. They're sort of having limited holidays because you can't even get relievers. And you and I know this. We've discussed this dilemma we have with workforce shortages in pharmacy. But those pharmacists need to plan, where is my path to making sure my pharmacy can provide these full scope services? What can I do from a premises legislation? So, if you're doing a refit, claim the tap in the consult room, even though it's not mandatory. Claim the refit now so that you've got all the criteria of what you need. The Guild and peak bodies have been quite open. We're not as regimented in terms of this floor, the room must be so many metres by so many metres, but there are very good guidelines in the ROCGP and others, and there's enough experience now in the pharmacy groups that your group should be, like IPA would be able to tell you, if you're setting aside, 12 square metres, this is the best design. It needs to be close. The other lessons we're learning already from pharmacists up in North Queensland, it needs to be close to the dispensary. Because if you're triaging a patient from at the counter where perhaps an inquiry needs to transition into a consult room, it's no good having that room 20 metres away. It forms a barrier. And so we're learning every day with, all this has happened very quickly. While we've had a difficult time with the Labor government at a Commonwealth level, and now we've kissed and made up, we've had a love affair across the state governments and territory governments. We will look back in 20 years and think the golden years of pharmacy was our success in stepping up during COVID has presented us with opportunities. And for the pharmacists to say, I can't do any more because why the hell is the guild pushing so hard? This is the window of opportunity for us to embrace. Once we've got it and embedded, they won't take us off it. They won't take it off us. And that's why my message to pharmacists is, as tough as it is, please embrace these new opportunities, these services, or whether it's oral contraceptive continuing support for patients, depending on your state and territory. This is an opportunity we need to embrace because that's the future of pharmacy.
And just to pick up on that point, guys, from an IPA membership perspective, obviously we've got the protocols for each state and territory. We've got trained teams here that are helping our members and both set up clinic rooms and with workflow processes, and then with other programs. And, now we've got pharmacies with 5 and 6 clinic rooms that are busy all the time, that have completely sort of redeveloped their practice model. So, we've got the trained team. We're here to help. And I know that we've done a lot of work with the guilds to make sure that we've got that information such that it's available for members to have at hand, to your point. Because often the hardest thing we hear is, what do I do? If I can't do 5 things, what do I do first? Any advice for members who are confronting?
I think that's a very important question. Obviously, from a business point of view, you take the low-hanging fruit where you get the most return. So, in terms of professional services of pharmacy, and I deem these in that discussion, generic substitution is number 1 and will be for a long time from what I can see. Number 2 then is biosimilar substitution. And because there's enormous opportunity, we look at the wave of biosimilars coming through. 9 of the top 10 drugs on the PBS by dollar value are biosimilars. That's number 2. Opportunity in terms of the DAAs. Even now, the average DAA revenue has jumped now that the cap is 90 patients per week. And so I haven't even discussed so far. We've gone to the top 3 that should be the priority for each and every pharmacy. And we're not even discussing any full-scope vaccination service or injectable medicine services. But there are huge opportunities, I think, so that people who've gone this far into it, to get some value is, obviously after that is the NIP, the National Immunisation Programs. I think it's also time that pharmacists revisited opioid replacement therapy. These are uncapped programs, Andrew. Yep. And I'm saying pharmacists, our members might say to you, well, I'm not comfortable with that, or my staff are not comfortable. It is time we review that, remembering you have the ability to handpick whether you're comfortable with 5 patients or 10 patients or 15 patients. That's the beauty of opioid replacement therapy. COVID-19, I still think is a big issue and will be for a period of time. And then we go to meds checks and diabetes meds checks, HMRs, the state government programs, third-party programs like pharma programs and the like. But I think, we also, just for those listeners who've stayed on for this far into this interview, our long chat, Andrew, I'm saying that one of the big sleeper issues coming forward is this e-prescriptions, tokens and active script lists will be actually added to the health app.
Yeah.
Now, once that will become what we call a killer application. So there's a lot of pharmacy groups that have got their own apps, but in my humble opinion, the consumer who can see on their health app all the prescription records, be able to see their pathology results, be able to see their doctor records, that is what we all have to embrace. So if you can embrace that customer and sign them up to active script lists, that's probably, if I'm being honest, the number 1 priority. If I was saying to a pharmacist, I've just taken or bought a business, what is the biggest multiplier effect on my bottom line that I could have is converting people to active script lists. From a patient's point of view, they'll know when they're running out of prescriptions. On things like the Prolia program, there's no repeats on Prolia. We find on average, people lapse 21 days. That may not seem important to you, or a person who's taking their interval, in other words, for Prolia is 6 months and 21 days. But it makes an enormous difference, because if that's the average, there are people outside of that 7-month range intervals for their Prolia, which is having an impact on their health. And so I'm saying active script list is one of the priority items that the pharmacist should be focusing on, so that we reach the scenario. Let's go a year down the track. So we're now July 2025, and on that health app, the patient will see when their COVID injections are due, if the state government has had a flu vaccine program, whether the pharmacist could be able to trigger the person should be having their flu vaccine. By then, on top of that, the pharmacist will see what repeats are remaining on an electronic token. And so that patient, and bring that patient close to the pharmacy and doing the DAAs and the other add-on services we're talking about will be the biggest profit builder for the viability of the pharmacy. And so that's why it's important for pharmacists to keep continuing to attend events, whether it's the IPA conference or Pharmacy Connect or those events, because some of these things will take what I'm proposing now is I would add a modest target of 20 patients a week. I've done this with pharmacies in terms of recommendation, and at 20 patients a week, there are some, depending on the pharmacy, but something like 600 patients account for 80% of gross profit dollars in a pharmacy. That's a lot of gross profit dollars in terms of percent from a relatively small number of patients. So we need to become more scientific to make sure that out of your top 200 customers, have they all been offered a DAA? I'm still surprised when I look at lists that we bring to the attention of a dispensary printout of in terms of patients who've had the most prescriptions in a pharmacy. And I'll give you real figures. The figures are around 1 in 4 patients are not offered DAAs, or they're not on DAAs. Now, some patients are fine, they're independent, but by the very nature of medicine misadventure, if you're expecting the person to handle 5 or 6 chronic therapy meds and they don't have a DAA, then I can put to you that it's likely that they're increasing the chance of medicine misadventure. So the business case to tell that patient they should have a DAAs and therefore bring all their prescriptions into your pharmacy and have them serviced and much more compliant and concordant with the medicine is one of the opportunities we need to do. So these aren't principles that have just appeared now in HCPA. They've been around for a while. But, we've had crises after crisis over fun. We had COVID, then we were whacked over the head with 60 days. But now is a good opportunity to sit down with your staff. And I suppose the killer line for me is, now is the time to revisit job descriptions, to revisit performance reviews, because in the job descriptions, I want to see where the pharmacists have got NIP against their responsibilities. I want to see where pharma programs is listed against their responsibilities. I want to see where the performance reviews have these as a formal review every 6 months. Some people recommend this yearly. I personally believe it should be every 6 months. And I know some innovative pharmacists are doing it every 3 months. That is a very organised pharmacy who can organise a performance review every 3 months. Yeah. But at the very least 6 monthly, there's so much happening in pharmacy. Most job descriptions now, if you've done them longer than 12 months ago, certainly if you've done them longer than 2 months ago, they're already out of date, because we've now got 8 CPA, which should be, a lens should be put over those agreements, over those staff agreements, position descriptions and performance reviews in that period. And it's also then non-threatening. Everyone knows there's an agreement, there's a roadshow with the president, the national president, there's a state roadshow. If we all of a sudden, if we were sort of out of left field and people say you've got a performance review, some pharmacists would have the fear of God in them. Whereas now is a great opportunity just to set a new course, review what's going on, and embrace these opportunities, because, you can't keep depending on the guild. The other pressure I feel sorry for the guild is increasingly, we've got many pharmacies, as I said, the 2,000 pharmacies that are not participating in any sort of injection services. They're putting pressure on themselves and pressure on the guild to making sure the dispensary service is viable. And yet we're getting each and every day pressure on health budgets that you just have to see the sort of pressure the health minister is under and governments are, whether it's, other health departments, Medicare. We've got the National Disability Insurance Scheme putting enormous pressure on federal Commonwealth government budgets. And that's why I think, there's enough here for pharmacists to be excited about the future, whether you're an owner or whether you're an employee.
And so, it sounds like, really, to recap all that, it's a time for investment. And whenever you're sort of investing it from a business context, you start with a strategy, you then have a look at your structure, your people, your training, you have a look at your systems and processes, and then have a look at your measurement criteria and reporting. and then do it all again. So it sounds, certainly, I mean, that's what we're seeing is it's a time now of security for 5 years. We've got the tenure of HCPA and an opportunity to invest. And so I think you're 100% right. And you're talking about pharmacy taking that coordinator of care role and starting to define what it's going to look like in all the communities around Australia. So now I thought I'd hit you with a couple of controversial ones because I know that's where you do your best work. Vaping. I mean, we've seen this, this policy, whether it's well thought through, someone else can comment on that. What's your advice to community pharmacies as we look down the lens of sort of OTC vapes?
So importantly, at the moment, we recorded this early in July, depending on when people are watching, and at the moment, when you've got Guild Insurance saying they're very concerned about coverage and professional indemnity issues, then we need to pay attention until we've got a letter of comfort from the Guild in terms of whatever protocols are put out. And I'm worried that pharmacy's been set up to fail. Yeah. So what I mean by that is, a nicotine replacement therapy protocol would cover 8 to 12 weeks of therapy. Theoretically, then, patients are on vapes. It's an 8 to 12 week program. Are we going to be seen? Because everyone's telling us that vapes will be seen as a nicotine replacement therapy. So, and people weaned off the vapes over a period of time. My concern, doing the research that I do as a consultant, I'm saying 95% of patients presenting at a pharmacy have no interest in quitting vaping. Yeah. So therefore, those 95% of patients, if you've got 20 patients and 19 odd of those haven't quit after 12 weeks, will pharmacy be seen as a failure? So at the moment, the protocols, all the language is around it being a weaning off period, and therefore instead of that protocol and that clinical service being put to the doctor, don't forget there was going to be about 400,000 extra doctor visits, MBS items a year. Pharmacies getting nothing. I just want to repeat that. Even the most conservative estimate was saying there'd be 400,000 plus MBS items. That's fees for the doctor to sit down with these patients and consult. Pharmacists is not getting anything. And so I fear that there'll be a very competitive price point pressure put on pharmacists by these manufacturers. So I still think it's early. There are pharmacies participating in the prescription model that will continue from 1 July to the end of September. Yeah. There's certainly a lot of water under the bridge to go. And my message to pharmacists is don't rush into these decisions. We need to make sure that whatever we're doing, you've got your professional cover. And, I foresee that I'm looking forward to the TGA have announced, even though the first has come and gone of July, there's been a commitment in the pharmacy press that guidelines will come out from TGA. And we've got to review those to say, will it still be within the framework of pharmacists supporting cessation of vapes? Because that's where I don't want pharmacists to be set up for failure. And that may have a flow-on impact for our full scope wishes. And to be seen where I'm always a little bit, putting on my Guild political hat, I'm always concerned when the AMA says this is a great idea. Let pharmacists do these as S3s. So that alone should be alarm bells for many pharmacists, because the AMA has never done us any favours in the 30 years I've been involved with official pharmacy. And so I think there's still a long way to go. And, I need to know from a professional indemnity point of view, if there are other services in the past that the pharmacist didn't do that, there was an obligation for the pharmacist to promote that the pharmacy wasn't, for example, pharmacies that weren't participating in emergency contraception had obligations to put signage up in their pharmacy. They had obligations to facilitate that supply at another pharmacy. Yeah. So here's the same. The minister is on record as saying he doesn't expect every pharmacy to do the service. But is there an expectation that those pharmacies will effectively be promoting services at another pharmacy, which is not the way to go? That's the other downside of this. If you choose not to participate, what obligations will you have in terms of signage to consumers about your non-participation? That's very unfair on pharmacy as well.
And it's feels a bit like another example of rush policy without the necessary sort of collaboration. So I know we'll watch this space carefully. Now our time together is coming to an end here today. I might just do a bit of a recap, and then I know Kos in true Kos fashion, I'll give you the last one. I mean, the things we've covered, HCPA, I mean, messaging is clear. It's a great agreement. It's a time to invest. Uh, uh, the funding is strong. It's a time to have a look at your business model and review it, certainly from an IPA perspective. That's what we're here to do. We've spent over 20 years doing that and supporting members in doing that and looking at things like generic substitute, biosimilars, DAAs, NIP, opioid substitution, full scope, COVID meds check. So you'd have to say the opportunity is many and varied in the sector, and that it is indeed a good time to be in pharmacy. Kos, closing words.
Well, I think right now, where we are in the calendar, there's going to be a roadshow. So pharmacists, there's a lot of fine print. Pharmacists, I think, have seen the big headlines, but there's a lot of elements of this agreement. So I would encourage you to go to the national roadshow that Trent, the national president of the Guild, is running. Then, depending on where your location is, there'll be regional meetings by the state presidents of the Guild. And at that point in time, I think you should be going back to your teams and having a big meeting, a 90-minute, 2-hour meeting with your team. If it needs to bring them after hours and you need to give them remunerate for that time, I'm saying that's money well spent. And then at that point in time, review the issues that we discussed. There might be champions in the pharmacy who are ready to put their hands up about some of these programs we've referred to. For pharmacies in particular, the easy wins are for those pharmacies who are not doing the maximum number of patients, the 90 patients a week for DAAs. That's one of the quickest elements you need to implement. And then I think that the opportunity is to, once that's in place, look at the physical environment of your pharmacy, because the advice categories, pharmacists, what we're having is this, my last words to my colleagues is, there is a drag effect with full scope. So if you said to me in Queensland, where the state government has announced effectively pharmacists are largely responsible for contraceptive health, injection, oral contraceptives, oral therapies, that would never have occurred unless we had, at the extreme end, full scope with pharmacists autonomously prescribing the contraceptive pill, etc. And so that it's almost like a comet where there's a wave coming in behind, and pharmacists need to plan their physical environment, the consult rooms that we referred to earlier, and getting support from IPA and others, because these aren't inexpensive to fit out. I think the groups are in the best position to advise pharmacists on that. And even if it's a 2-year plan, have a plan to have that consult room. So my final message is, I would hate to see that we're talking in a year's time in July 2025 and we don't have every pharmacy in Australia with a consult room, where at the very least a visiting credentialed pharmacist can come along and do their services, because that's where the future of pharmacy is, and that's where an increase in revenue flow will be. So we wish pharmacy all the best, but obviously there's also a lot of support out there. So the other great news is there's lots of support out there for pharmacists from their professional organisations and from their groups such as IPA.
Kos, thank you so much for your time. Insightful as always, and look, I look forward to when we can next discuss the issues.
Cheers, then.
We're dedicated to supporting a network of leading independent and bannered pharmacies nationwide, with a vision to connect all member pharmacies under the IPA national brand, recognized by Australians for elevating community healthcare to meet local needs. Thank you for joining us today on the Pharmacy Podcast. We appreciate your support in our mission to shape a thriving and patient-centric pharmacy industry. For more information about independent pharmacies of Australia, you can visit our website, ipagroup.com, or stay connected with us on social media. Thank you once again for joining us. We look forward to welcoming you back soon as we continue our journey together, enhancing community healthcare